Good afternoon, everyone. Thank you very much for being with us. And then maybe I think it's time for us to get started on time. Okay. As part of this parallel session, that we are discussing a very important topic that's on the national governance. And then the title that we have here is Fortifying National Systems for the Age of AI. And let me actually quickly give you the background why we planned this session. And certainly, like I think everyone is aware without doubt that why there needs to be a dialogue, a collaboration, and cooperation in this approach towards national governance. And then they need to involve also the diverse stakeholders, and then in the governance of AI, and to put it in Ahin's language, and then also our mantra on convergence workshop, where we bring together multiple stakeholders, all those who are relevant for the national um, digital health strategy. In this case, like AI also like is part of that. How we bring together those multiple stakeholders together and then get them to see the national vision for AI, and that also includes the governance as well as how we manage it. So we have here speakers from a very broad spectrum of backgrounds, and so I'm sure that they are going to actually bring very diverse views and perspectives. And quickly, we'll run through the objectives. So to establish a conducive environment for governance of health technology and AI in national healthcare systems, key principles and considerations for ensuring safety, equity, and inclusivity in the development and deployment of health technology and AI, regulatory approaches and policy recommendations aimed at addressing ethical, legal, and social implications for healthcare AI, case studies demonstrating effective national governance models, stakeholder alignment, collaboration for consensus on governance strategies. Through sharing of knowledge, experiences, and best practices, the session seeks to advance the development of effective governance frameworks that can support the responsible use of health technology and AI in countries and for the benefit of all individuals and communities. And now I have pleasure of introducing the moderator for the session, Mr. Mark Landry. He is the program officer for the World Health Organization here in Thailand. Over to you, Mark. I would like to invite Mark, and then he will actually take over the session and then also bring in the speakers in this interesting uh, type of interaction, I would say. I would leave that to him. Thank you.
Great. Thank you so much, Jay. It's I'm going to actually just sit there for now. It's a real honor and privilege to be able to moderate this session. And I don't know if folks in the room are familiar with this style of a moderated discussion, and this is the approach we're going to take today. I think many of us, who's been here since Tuesday? Show of hands? Okay, just about everybody in the room. So you may have experienced some PowerPoint fatigue. You may be wanting to consider how we could shake things up. And so we're trying to do that with this last 2 hours, the last technical session for PMAC 2025. So these are the rules of engagement. We're going to have what we call a fishbowl style discussion. We actually have 7 panelists, or those who have been preparing for this dialogue, and we'll be bringing them into the discussion at different points. You in the audience are part of this fishbowl. You can see what ChatGPT came up, so don't be shy. If you want to be that fish swimming at the top and you want to jump in, swim down, take that empty seat, and come up, we will encourage that. If those of you know me and know working with me that you might be voluntold to come up to here, this is the fishbowl. There'll be an empty seat all the time. And so we will invite as much discussion as we go. So, what we want to achieve, as Jay pointed out with the initial objectives, is we do want to, build on the discussions that have been going on the last several days, and I think we've heard so much, and I think we all have our own not only background coming into PMAC, but I think we've all been edified and have a lot of our own reflections. And so, again, through this style, we hope that you might contribute to the discussion as we think about effective AI governance frameworks, actionable steps for inclusion, for equitable, participatory, transparent, accountable mechanisms, and then what might be some ways to think about collaboration in better and new ways. So the first fish or speaker, I'd like to invite Anurag Agarwal, who is from the Digital Transformation for Health Lab in India, to please join me up here. And we're inviting Anurag to really set the scene. And we decided as a group that we wanted to bookend, or let's start about, I think, what we've all converged on the last several days from the beneficiary's perspective, the clinicians, the patients' perspective in this transformation with the use of AI. So we want to start with that as an entry point for our discussions this afternoon. And we will work our way through various aspects and dimensions of this, and we'll come back to that towards the end. So with that, Anurag, if you'd like to help us with some scene setting, that would be fantastic. Thank you. Over to you.
Thank you so much, Mark. And typically at this point in a session with multiple parallel ones going on, you're always wondering, why do I have to be in this session? Why can't I be in the other session that sounds so much more interesting? So when Mark proposed the idea of the fishbowl, one figured that one could be a fish that swam away. So I thought I'd get that started. But anyway, I would like to draw your attention to the fact that we are talking about fortifying. Now, the literal meaning of the word fortifying is to strengthen, to protect. And we are talking of the age of AI. At one level, our meaning could be that we are talking about using AI to protect against a variety of challenges that come across our way in healthcare. Another meaning is that we are expecting trouble in the future. And we saw some wonderful movies yesterday about AI as a young child. And we are thinking about how to protect our systems against unintended consequences in the age of AI. And I think that movie that we saw yesterday was just amazing in how it brought out that AI by itself is neither necessarily good or bad, it's just another tool. And how we train it, how we use it, will determine its implications for health systems. So, who is it that we are worrying about? The patient, the clinician, the entire health systems, all of the above. And if you really start thinking about it, we really, if we want to fortify health systems, we need to be worried about all of them at the same time, not ignoring any one for the other. Ultimately, the doctor has to deliver care in the same system. The patient's interests have to be protected, and a good, lean but balanced governance ecosystem is critical. So I'll touch upon three very basic themes, try to take as little time as possible to allow more voices. The first is data. Now, the reason data becomes critical, we had a full session on it earlier today, is ultimately when we talk about training AI, we are dependent on data. Yesterday, we heard that while about half of the people in the world live in Africa and South Asia, only about less than 10% of genomic data is there, which basically means that if we were to use genomic data for drug discovery, trying to optimize efficacy of drugs and stop the drugs likely to have side effects based on genomic data, we are likely to create drugs that are either ineffective or harmful for the majority of the people living in this world. Now, this data challenge regulatory in AI is again in two parts. There is a primary problem, there is no data. And there is a secondary problem that even when there is data, it's either fragmented, not easy to share, and fear of data colonialism of exploitation is preventing people from sharing the data. The first will take time, but a good regulatory ecosystem built upon principles of data solidarity as opposed to the principles of only consent. Always think that the standard ways of if you got consent you can use it are fundamentally flawed. Every time I go on the web, there is something I really want to use, and there is something saying I agree. The first thing I do is I click on it. And I'm a relatively educated user. The point is, if you got a lollipop to give, you can get consent very fast. The real principles of regulatory systems is to ensure that malicious use that harms people, is prevented, while use for other purposes is made easy. Any ecosystem that does not follow this as a primary principle is doomed to fail, and simple content privacy architectures are simply not going to work. The second big area is priority. Now, what is the priority? You hear periodically of shiny new applications of AI, and I'm not saying they're bad. I mean, they're fantastic. The large multimodal models are superb. But the priorities of simple, good old fashioned AI, including the new generation from time to time, in enabling people who are less skilled, in reducing the burden of overloaded doctors, and informing patients in ways they can use the health system better, is perhaps the biggest priority. But it attracts less attention. But I was very heartening to see in the course of this conference in this region multiple good examples coming this way. So, setting priorities towards actual applications for global health, I think, is absolutely critical. And the last thing I will say on this is looking towards the future, looking at young people. And I mean this in two different ways. In a former commission, Lancet and Financial Times, looking at AI and digital health for young people, we realize the future of the world is in delaying the onset of illness and promoting wellness when you are young, and the priorities for that are very different from priorities for disease. And this ecosystem will be built by the current digitally native generation and enabling a person anywhere in the world to contribute to this vision at a time when digital connects the entire world together is going to be really important. So it'd be lovely to see a type of an ecosystem. I'll just use India as an example, where a young person living in India, interested in tuberculosis, would seek to make a difference for the problems plaguing his region. It's absolutely fine if they choose to work on problems that afflict any part of the world, but they should be aware of what matters where they are, and they should be provided the tools to doing so. And when we speak of regulatory frameworks, I think this is what I would like to see: a good data ecosystem, a good regional set of priorities, enabling young people, and in consultation with them, preparing for the way forward. And I'm going to end my address here, and you'll get far better views from young people on the panel as we go forward. Thank you.
Great, thanks, Anurag. Appreciate that. And so putting that into perspective from the lens of prioritizing the use of data and investing in young people. So a couple of amazing young people I'd like to invite up. I always like to hear from country experiences and considerations to also kind of help set the scene. So Farah Maghrabi, if you could come up from the Australia Alliance for AI and Healthcare, as well as Zoe Lagvajav from the Mongolian Society for AI and Medicine. So I think it's important that we hear from your experiences from the work you're doing in Australia and in Mongolia. I know you do have a few slides to share just as a way of introduction here. So let's hear first from Farah, from you, and I'll let you click if you'd like, or
And meanwhile, I'm going to be the fish that goes down.
Can you go back one? Great, thanks
Okay.
very much. So hi everyone.
Thanks, Anurag.
Very much for the opportunity to address you here today. I'm Professor Farah Maghrabi from Macquarie University. I also represent the Australian Alliance for AI in Healthcare. I serve as the co-chair of the Safety, Quality and Ethics Working Group. So for context, for those of you who are not familiar with the Australian health system, we're a public health system. We're a federation of states and territories. And in response to some of the points that were raised by Dr. Anurag, we have taken a very sort of problem-based approach to AI in healthcare. And that's essentially, the Alliance is a national group of stakeholders, for over 100 stakeholders, that involves representatives from academia, clinicians, health service, consumers, and industry. It's been going for about more than 6 years now, so from 2018 onwards. Essentially asking the question about what we need to have in place to ensure that we adopt AI sensibly and safely in the Australian health system. And so it's a very problem-based approach. The stakeholders came together essentially by consensus, decided on the priority areas, which are on the next slide. I'll just get to that in a second. And the other thing we tried to do by design is to integrate AI governance into existing governance processes. So let's face it, the health sector is highly governed and regulated already, and we don't want AI to introduce extra burden for the people on the ground. So the approach we took in Australia was to exploit existing governance processes that we already have for patient safety, as well as for digital health. And what we came up with is the National Policy Roadmap. I mean, you can scan that QR code. You should be able to access the whole policy roadmap. The other, and I'll get to that in a second, I'll show you the policy roadmap. But before I do that, I also want to say one very interesting thing that we have done in Australia is we had a citizens jury. If you could get the next slide up, please. So this was a national citizens jury. If you're not familiar, it's an evidence-based process for recruiting a nationally representative sample of the community. You educate them about AI over a number of weeks, and then they come together face-to-face for deliberate, essentially asking the question, how do we want to implement AI in healthcare and under what circumstances? And essentially, that's the jury there in the picture. The summary from that is that Australians welcome the application of AI in clinical areas, but they don't want anyone to be left behind. So that's available online if you want to go and have a look. Now let's get to the next slide, please. Let me take you briefly through the roadmap. It has 5 priority areas with 16 recommendations, and I'm not going to go through it all today. But for example, in safety, quality, and ethics, what we looked at was how would we integrate safety measures into existing safety processes, so for the national standards. When we're looking at ethics, we have a national AI ethics frameworks. There's a lot of frameworks out there, and so the question is, we don't need a new one for health, but how would we adopt it and make it health specific? It's very much geared towards the community. So with consumers, it's what do we need to do to bring the workforce as well as community members up to speed in terms of digital literacy. We have a significant First Nations community. So again, that's a community that has special needs and needs to be accounted for. And then finally, with industry, there's a growing industry that we have and we want to support. So how do we sensibly provide them access to clinical data to build their systems? And I'll kind of stop there. Thanks, Mark.
Thank you very much for that. And so before I go to Zoe, if anybody else wants to come up and share from your country perspective, so what I'm going to ask Zoe to build on this is, in Mongolia, what have been ethical principles that have guided AI policy and deployment in healthcare that helps you balance between safeguarding patient rights, privacy, and data security? So let's go to a couple of slides that you have, and if anybody else wants to come up from the audience to think about how this is unfolded in your country context, please do.
Yeah, thanks, Mark. So we are a Mongolian Society of AI and Medicine, and it's a very young organization. And my colleagues at the Mongolian Society of Artificial Intelligence and Medicine in 2021 developed the Ulaanbaatar, which is the capital city, Ulaanbaatar principle of ethics and artificial intelligence in medicine. And we have 6 principles, but I don't want to also go over each and every one of them, but I want to highlight maybe one or two on that. But so, for example, transparency, it's very important to for the AI models that the planning and research and data and development, all of the process must be transparent. And on top of that, it states that any limitations or shortcomings must be also clear to the public and also as well as the professionals, because it's very important for us to know what an AI is and what AI is not. Because I don't want to say it, but AI is such a buzzword as well. So we really need to know what it can do and what it can't do. And then I don't mean that the physicians or the patients as a user, they need to have a professional level, technology level knowledge, but as a physician, they need to know what could be the important considerations when they're using the AI-based solutions, and what is the generalizability, and also what kind of bias it could bring, so that we know how to use that AI responsibly as a users. So that is very important we included in that. And then maybe I can also want to mention from Mongolia perspective, because our culture is pretty unique, and we have many rural people living with a nomadic lifestyle, and that is a very unique, but I don't think we only have a nomadic lifestyle on the world. There must be like people in Africa, people living in Central Asia. They have a very unique that makes it very hard to deliver healthcare for them, because they don't have a fixed address. They don't likely have a very good internet access. So we also wanted to bring as the accessibility principle. We need to tailor the AI solutions to their culture, to their lifestyle. And I also think it's at the global level, it's important to have a certain culture sensitivity. So I think I will end here. And yeah, I have some more to add, the human dignity, etc. But if we have time, I'd like to add too.
Great, thanks. I think something that you've reflected on, both of you, is building on what already exists in terms of existing regulations, frameworks. These are not new principles. These are not. They're just tailored, maybe, and tweaking in the age of AI. And so I'm going to maybe volunteer Dr. Sarakamith, if you could come up, please, from Thailand. Before he arrives, come on up, grab a microphone. Come in, jump in the bowl. Hey! Because I think this is not anything new, and I think because I work here with you in Thailand, just you can jump out after you take this question. Yes, from the Ministry of Public Health.
I feel like I am a goldfish.
Yes. But
Okay.
share from your perspective, how are you dealing with the digital transformation agenda, absorbing the power of AI and planning towards adapting and adopting your policies, your regulations to be fit for purpose? How are you getting AI ready in terms of your regulatory and governance frameworks?
Okay, so let me drink a little bit. In 2017, we first know about AI because the Ministry of Public Health was invited by Lithuania. Let's say we were introduced to AI of chest radiography by sending me to Lithuania Baltic Lifestyle meeting, and at that time there was the AI chest radiography introduced into Thailand. And from 2017, we have around, currently we have 400 hospitals from 900 hospitals across Thailand that is using AI for chest radiography in our hospital. So we use it routinely for tuberculosis screening and lung cancer screening. So that set the framework, because from 2017, we know that we can use AI for chest radiography. And then around 2018 or 2019, we worked with Google to develop the first retina scan by AI. And that is the second AI that we know is work for diabetic retinopathy screening. So from that to new tools, we learn also we need to regulate them. So we set up the AI strategy in the municipal health from 2018. So we had that from maybe sorry, I didn't prepare for this, 8 years ago. And then at the national level, we have AI strategy a few years ago by the Ministry of Higher Education and the Ministry of Digital Economy. This is very important strategy because two ministries have the same AI strategy. And in Thailand, we have two AI strategy from two ministries at the national level. And that set the scene for the municipal health to do AI health regulation. So that is the overall scheme. And in terms of the governance system, we do not actually have the governance system for that because we consider them as the medical device in the municipal health at the moment. So in general, it's just a medical device. So we put them under the medical device regulation. But given the large language model capability, currently we are learning how to use it. And we install the Llama model in the municipal health data center last year. And now we know that they can do a lot more. And then this is the first time maybe that we are trying to put together the AI governance for that large language model things in the municipal health. So that's maybe I can share this at the moment.
Yeah,
Okay.
thank you for that. So yeah, I think there's been a slow but steady recognition of the power of AI and adoption and use in some priority areas. So in the spirit of thinking about principles and ethical considerations, I want to invite Patty Michelle to come. She's the co-founder and CEO from Health Enabled. So I think, Patty, this has been an area where I think you've been focused on in some of your work, but it's come out in virtually every discussion. So as you've been ingesting, thinking about AI governance frameworks in terms of prioritizing equity, looking at inclusivity, gender representation, marginalized populations, fairness, underserved populations, et cetera. Could you reflect on that from your own experience and what you've even learned from the last few days? And appreciate to hear your perspectives next. Thanks.
Sure. Thanks, Mark. And so I began my work in technology and health in 2002 when I was doing my PhD research on mobile phones and health in Egypt. And even then, there were like huge divides, right? Like a lot of the technology, internet was developed, largely in the United States. The content was mostly in English. There wasn't, and then, mobile phones came on the scene and there was this proliferation of mobile phones. Again, most of the content was in English. And so we've been in a technology ecosystem that is like a massive digital divide, and it has never corrected itself. Like it's never been like representative of the global population, and it has never been designed to promote equity. And I think we need to kind of go back to the basics and really look at the underlying ecosystem and then see like where it's possible to like adapt and adjust things so that, the real benefits of AI, which is, frankly, to me, I think it's like the hyper personalization, right? You can hyper personalize like any type of education or health service, but you can only do it if like the data that's coming into it is representative of the populations that it's meant to serve, and the technologies and the architectures that are like designed within the technology are designed in a way to benefit everybody. And it just hasn't been that way. And then you add that sort of, unequitable, unrepresentative, frankly unfair digital ecosystem, and then you put it on top of health systems that are, where we have significant access issues already, then the divides just become like even more exacerbated. And so there's a lot of discussion in the AI, universe around accuracy. And so everybody's like obsessed with accuracy. And it's like, to me, it's like, okay, great. That thing that you wanted it to do, you were able to do. But what is it going to look like in the real world? And so I was really, excited when, both Zoe and Farah mentioned, different principles, because I think that's really what we need, is we need these principles that are going to enable us to really think about, okay, what are the really good use cases and important use cases where we can apply, AI in a meaningful way? And how do we ensure that the way that we're doing it is like ethical and fair and representative of the populations that we're trying to serve? And I think we have to look at local. I think we have to go sort of like bottom up, right? That the AI systems are as good as the data that's in them, as Anurag was saying earlier. And so if we don't have data that is truly representative of the populations that we're like aiming to like serve, including ourselves, right? Like we're all part of an ecosystem. Then it's just gonna exacerbate already existing inequities.
Excellent, excellent. Appreciate that. Now, going back to just one priority area, as Anurag has challenged us to think about, in terms of service delivery and the clinician-patient encounter and the tools and approaches for, different opportunities to amplify that engagement with more efficiencies, addressing workflows, et cetera. So for all three of you, and then after this question, if you would like to step down or even hand the mic or bring it to somebody in the crowd to replace your seat, that would be wonderful in the fishbowl. But how do we deal with, how should AI accountability and liability be structured among this community, from the developers, the clinicians and patients and policymakers, really to ensure that we are ensuring ethical and effective implementation? So, how do you create that context to get all of that input? Because I still think we're just dabbling, we're trying, we're experimenting. We have some good examples, perhaps that even Sarakabeth has mentioned. So tell me what you think about this issue with accountability and liability with all of these stakeholders in mind, from developers to the point of delivery of these AI-enabled services between the clinician and patient. Anyone of you jump in?
I can take a stab at that. I think we need to really think about the applications of AI, and most of the AI we have today are largely assistive, in the sense that it's a second pair of eyes, it's the scribe that is summarizing, and so it's back to the clinician to verify the AI provided information. And that's essentially backed up by the evidence. So we have reviewed the literature over the last couple of years looking at RCTs, as well as all of the medical devices that have been approved by the FDA, and about more than half of systems that we have in place today are assistive. So the liability in those cases goes back to the clinician. It's the learned intermediary. But I think as we start to automate more and more, then that will need to be looked at. And that's an open question, because it depends on the risk level. It depends on the application area as well. And so there's lots of work for lawyers, I think, going forward.
Yeah, I just wanted to add on, if you go to the principle from our society, there is the human dignity part. I guess that's what I wanted to touch a little bit too, because on our principle as well, So it needs to respect human autonomy in decision making. That kind of implies that the physician, nurse are the ones going to make the decision at the end of the day. But then that also implies the responsibility would go to the physicians. But then if we go to the next slide, I really think that's important principles as well. That's just a clinical decision support tool, right? But it's not the AI, but the 5 rights principle. How you really need to have that 5 right correct when you are implementing a clinical decision support tool. And then if you don't have that everything right, it really disrupts the clinician's thinking pattern, and it can really take away their focus, and it can kind of almost like push the physician to make a mistake, right? But then if the physician is bombarded with alert and they are suffering with alert fatigue, how are we expecting them to make a right decision and then just say, oh, at the end of the day, that's your responsibility to make the decision? So there must be certain, it's a very hard topic, right? We don't have the clear answer, but there must be certain consideration whenever the clinical decision support tool or AI algorithm is involved for the decision and for the mistake during the healthcare delivery. So yeah.
And I think we need greater digital fluency in like the general population and in like the health professionals, right? I think people need to have a much better understanding and appreciation of, I think we talk about digital literacy, but I think it has to go like way beyond, you know, basic understanding, because it's becoming more and more complicated. And I think there has to be more demand generation in terms of like holding, you know, the private sector like accountable for what, you know, is being done with people's data, and how it's being used, and that sort of thing. And the other piece is measurement. I think, you know, that which is measured gets done. I think we need a lot more transparency and like systematic evaluation of AI and what goes into AI. Like, what is it being trained on? Who's involved in the training? Is it representative of the populations that are meant to be using it, and having really solid representation? And then on the output and the outcome side, are the outcomes like fair, equitable, and are they doing the things that they're supposed to be doing? And then to Anurag's point about young people, you know, one of the slogans of young people is like nothing about us without us. And I think as like a global society, we need to be kind of like taking that like approach of like nothing about us without us. I mean, I'm sure lots of my data is being used for all sorts of stuff. But I think we need to become a lot smarter and start owning our own data and start controlling our own data, but then also educating people on how to engage with that.
Excellent, excellent. Thanks, Patty.
You came back.
I see Anurag is jumping back into the bowl. Again, I invite any of the audience, and I'm going to, people are coming in and coming out, so just to put back the rules of engagement for our fishbowl, please don't hesitate to jump back in. So, and while before Anurag steps in, Indira, if you can come up to your, I'll come to you in just a moment. Anurag, please, what's on your mind that you jump back in?
Liability. Liability is always on the mind of physicians. So one thing that we didn't discuss is at least one example of autonomous AI now exists, right? Occipit. So in the European Union, based on the fact that AI is superior to humans in detecting abnormalities on a chest X-ray, an AI determined normal is more likely to be true than a physician determined normal. So which basically means in one very specific application of occiput, which some countries have allowed, a normal chest X-ray can be reported back to the patient without a human being ever having seen it. So now there is no doctor in the loop. And generally speaking, litigation follows, and with all apologies to any lawyers, Litigation follows the principle of deepest pockets that you can go after. And so I would imagine that in time to come for autonomous AI, we will see a health systems that deploy these tools and the companies that supply these tools come up with internal agreements as to how to pay for the costs and claims of litigation that comes up. To my mind, that financial model is just beginning, but I do see increasing versions of it. And if we start imagining how we want to use AI to support less skilled people to do tasks they were never fully trained for, this principles of delegating the legal liability further up along the chain has to come. If it doesn't come, why would somebody who was not trained for the task agree to do it even with the support of AI? So just a thought over there.
I appreciate that perspective because I think we have to find where our safety zones for appropriate use for AI now. That is also evolving, and that net is increasing as more applications and use cases are addressed that become more mainstreamed and appropriate, ethical, etc. So I want to bring in Indira Kantiana from the Asia Center for Health Security in Singapore. And, when we talk about AI, and we've heard a lot of folks already say how important to have inclusivity and have more voices and more stakeholder engagement. And as I was alluding to before, how important it is that we have these perspectives from the clinicians, the patients, a lot of these principles. These are not necessarily new, but we still need to hear from the beneficiaries is one group, because their perspectives are vital to understand where are their pain points, where are these opportunities that AI might increase efficacy, lower the burden, remove some of the inefficiencies in workflows, et cetera. But now broadening that stakeholder engagement. Indira, maybe you could talk a little bit about what role civil society plays in shaping AI governance frameworks to ensure this transparency, accountability, and public trust. And as I think Anurag is making an important point around liability as well. So maybe you could start with that. And again, I would invite audience members, please jump in the bowl. Please, Indira.
Thank you, Mark. Pleasure to be here. So I'm speaking today having experience working in a civil society organization in Indonesia. And so when we talk about, trying to create this ethics and regulations, before we even go there, I think it really depends on who's sitting at the table. And we really have to acknowledge the power dynamic that exists within AI development before we go even to start to regulate AI. And I think it is important for us to all to take a step back and really acknowledge that in the last, 5 to 7 years that AI has been rapidly developing, that it has been primarily driven by private technological corporations. And them having the vast data and technical capabilities and also financial resources, there is a risk of concentration of power, but also the risk of capture, meaning that AI development is not necessarily driven for the purpose of public health or equitable health, but it is actually just for profit generating interest. And with this risk in mind, while we do want to support innovation and it has to still be balanced with equitable health being in mind. And governments cannot work alone. And this is where civil society can come in and have a play in the governance of AI. A whole of society approach needs to be taken into account. A multi-stakeholder collaboration needs to be more encouraged. And like you said, when we talk about, Patty talked about representative of data, but a lot of these vulnerable groups don't actually have a voice at the table. And this is where civil society can help advocate for those inclusion and equity. For example, in Singapore and Indonesia, civil society have worked with people elderly people or people with disabilities, and just kind of working with additional software equipments that's needed for them to closer that digital divide. But also on transparency and accountability. Even when government and corporations, even when we introduce those regulations, but who's actually holding them accountable? And the nature of civil society being non-governmental and non-profit typically, this is where they kind of come in as like a watchdog, trying to make sure that human rights-based approaches are actually being considered, and not only during the implementation, but throughout the AI lifecycle process. And also just help monitor whether the whole process of AI, from the inception, from the development of AI to the implementation, and also the monitoring and evaluation, are in accordance with the ethical principles. I think I'll stop there.
Great, thanks. Before I come to Anas, and Rasham Sethi is online. We have a virtual fish in our bowl. I'm going to come to you in just 1 second. But I just wanted to share, does anybody that is not from Thailand know about the triangle that moves the mountain of public health here in Thailand? Anybody heard that? Maybe raise your hand. We have Pak Rudy here from Indonesia that knows this. So this is, I think, quite profound. And the triangle is indeed from the policymaker is one point, civil society, community, and then the knowledge sector and academia, et cetera. And it's this powerful triad that really is applicable here, as you're alluding to, the voice, the watchdog, having that interaction is quite important. So I want to go to Rasham Sethi from PATH in India, and please, I think you have a lot of very interesting experiences, but from this multi-sectoral collaboration lens between government, private sector, civil society, academia, how can this multi-sectoral collaboration create more robust AI governance models? So you can speak to that, and then any other hot topic or point you'd like to make. Over to you, Rasham. Thanks for joining us.
Thank you so much, Mark. Hello, everyone. Good afternoon. Hi, Professor Anurag. I couldn't join in person, but this also sounds great. So I work with PATH, India and South Asia. I lead the AI efforts. I'm also with ORF as the US-India AI Fellow. It's an absolute honor to be here today and discuss critical aspects of AI governance. And the two questions that I'd like to focus on, and I have very 4 specific points of discussion there, is the first is how do we ensure ethical, fair, and transparent AI systems that serve all population inclusively? And the second is how do we balance innovation with governance to safeguard human rights and health equity at the same time? And according to me, the answer lies in a dual governance model where national and subnational, or you can say the provincial governance, work in tandem, and where civil societies also play a key and a critical role in bridging the gap between global AI principles and the local realities. So my discussions focus on very 4 specific points here, and it's predominantly for LMICs. The first is an urgent need for ethical AI in public health. So while AI is rapidly integrated into public health systems, improving accessibilities and delivery, I think the stakes are quite high for us to solely rely only on technology without governance and ethical structures. So key challenges as algorithmic biases, data privacy risk, or lack of explainability. There are studies that have shown that AI-driven health systems trained on biased data sets can misdiagnose patients from marginalized communities. So the question here is who holds these systems accountable? And the answer why AI governance must be a priority here is the need for the system to be transparent, accountable, and equitable. And where we have both national and subnational governance, ensuring that there is a seat at the table of civil societies to play a critical role in shaping these policies and holding the concerned people accountable for these mishaps. The second is the dual governance model, where we have a national and a subnational or a provincial approach. So effective AI governance cannot be a one-size-fits-all model. A dual governance approach ensures that AI policies are not just theoretical, but operational, practical, and adaptable to the different regions in healthcare realities. And why is this important? Is because healthcare challenges vary across regions, communities, populations. An AI solution that can work in an urban hospital in India may not be as effective as it should be in a rural primary healthcare center or a health and wellness center. So, reframing from one size fits all model, there needs to be a dual governance model to make the framework contextualized to specific regions and their population. The third is the role of civil society and stakeholder engagements in AI governance. So, when we're looking at building a trustworthy AI ecosystem, it requires a broad participation. So, drawing more on what Indira also mentioned earlier, it cannot be focused on the governance model, cannot be only dictated by policymakers or tech companies, but it should also be involving civil society, academia, multilateral organizations, and communities. And there has been a very significant study that was published in 2019 by Jobin, and he focused on very high level meta analysis and reviewed about 80 AI ethical guidelines and found global consensus around certain principles such as transparency, justice, accountability, and privacy, among others. The study also revealed a critical gap that there was underrepresentation of LMICs in Latin American countries over there. And we must change this. So that is why national systems must be fortified with civil society led organizations that could also be as oversight mechanisms, having ethical AI audits, and not just focusing on tech companies doing self regulations, but governments also integrating ethical AI frameworks within themselves and institutionalizing it through stronger stakeholder collaboration. Lastly, how can national, subnational, and civil societies work together? So, while there is a need for collaborative effort, there should be national level collaborations setting the AI governance frameworks where governments are focusing on establishing clear regulations, ethical guidelines, and data protection laws. While civil societies and the academia or AI experts, technologists, ensuring that AI aligns across the AI product life cycles and addressing the public health needs and human rights. The second is the subnational collaborations. So that's where the adapting AI systems or AI regulations to local needs come in. So states and local governments needs to translate the national level policies into actionable region specific strategies, developing AI state AI roadmaps, digital health roadmaps, addressing the local health priorities, infrastructure gaps, and demographic diversity. And lastly, civil society and a public private partnership in ensuring that the AI systems are ethical. So these CSOs playing a role of watchdogs, advocates, ensuring that AI remains transparent, and collaborate with governments and private sector players as well as international organizations to uphold the ethical AI deployment, contextualized and localized to that specific region. So over to you. Thank you.
Right. Thanks for that. And of course, I think you're reiterating so many important aspects that we're trying to embrace. That this is not only multi-sectoral engagement, but also trying to get every voice to the table and ensuring that we have all the appropriate input, both from an ethics standpoint, but I think also maintaining that that goodwill, that community, and the governance frameworks have to be dynamic, as you're suggesting as well, not only national level but even subnational level, because there's different contexts even within the health systems at different levels, between countries, et cetera. So appreciate that perspective as well. And I think I want to go now to Anis, who one of the risks and concerns that is out there is premature, untested, untried. You're welcome to go, Indira. You can come back anytime. How do we, from a regulatory standpoint, try to put guardrails to ensure that there is some testing or ways to look at these models and systems and tools from not only from the ethical standpoint but from a regulatory standpoint. And I think you have some very interesting experience from Indonesia. So this is Anas Fuad from University of Gajah Mada in Indonesia, and please share your work with the malaria work you're doing. Thanks.
Yes, thank you, Mark. I think it is a very important question, and I would like to reiterate some point that has been discussed before, especially about liability. If, for example, a hospital use any AI technologies, and then something wrong happen, who is will be responsible for this kind of condition? Whether it is the clinician, whether it is the director of the hospital, whether it is the regulator, the Ministry of Health that gives the license of these technologies could be procured by hospital. So the issue of liability and risk should also come from the regulatory perspective. So fortunately, as part of the academia, I have been involved in triggering this kind of discussion from the perspective how to fortify, how to strengthen the regulation in the early beginning. So in this kind of context, actually I'm working with my colleague in Department of Parasitology. We know very well that Indonesia, as a country with also still a problem with malaria, Indonesia have the target to eliminate malaria in 2030, and we still have a problem of malaria, and we still use the conventional or existing method to detect malaria, to treat malaria, and also, if possible, to refer malaria from the community level to higher level. When all the digital technologies available, we could order food and also consult to doctor using app. We could not use this, especially in a certain area. This is because of what? Because the regulation until recently, we do not have a regulation that allow a healthcare enterprise or a technology enterprise to use this kind of technology to change or to offer new solutions to the public. They receive a license from the Ministry of Informatics as the technology enterprise, but they are not part in the health sector. So it will become the issue if something happen in the society, if the doctors as part of the technological company provide receipts to the patient, who will be responsible? Because they are registered at the Ministry of Informatics, not at the Ministry of Health. So we come to the idea on how to implement regulatory sandbox, in which the idea has been started, I think, earlier in UK on financial sector. So may I have the slide? We started to develop the regulatory sandbox actually based on the situation that the current regulation is mostly very slow to develop any or approve any new technologies. Usually Ministry of Health discuss with the academia, a lot of time for drafting, reviewing, and even some experts that were involved in the drafting the regulation are not from the innovation or technology. They do not know exactly what is the going on with the risk of this technology. And then there is also another issue, for example, the cross-sectoral challenges. This technology, for example, the health technology, receive license from the Ministry of Informatics, but not from the Ministry of Health. And also another complex of licensing. Indonesia also follow the FDA on, I think, a regulation many of our colleagues knows very well about software as medical device, but it is a software as medical device. But some software could also be part of the solution in part of the enterprise. So it is some challenges that I think still happen in many countries. So that's why we propose on implementing a sandbox. It is a safe environment where the regulator and also the innovator and also civil society and also academia sit together to discuss, to see whether the business model is okay in the health sector, whether it is safe, whether it is secure. So at the time for malaria, we working together with the Ministry of Health, invite startup to join. Fortunately, there were 18 startups to join. And then about 6 months something, we discuss together and we see whether the technology could be useful in malaria, either for surveillance, either for teleconsultation, or either for external quality assessment to see whether the technology could also be used to support external quality assessment for microscopists. And we find out from 18, only about 6 that receive, we call this pass all the criteria on the safe technologies. So this is the first trial of regulatory sandbox, and currently the Ministry of Health follow this regulatory sandbox model. On the first phase, we had the regulatory sandbox for telehealth, and then in the second phase, we have also another 5 clusters for patient solution technologies, online marketplace, health profession education, and also wearable devices. So we are in the process to come ahead about how to improve the governance on new technologies, including AI.
Excellent. Stay there. I'm glad we have some more fish jumping back in. So if you were here for the plenary before this, you heard from Phil from the Africa CDC. They're doing this in Africa, at the Africa CDC, developing this regulatory sandbox. And I think it's quite important. So I think we're onto something here. So we have Patty back, Indira back, but I'm going to put them on warning because I saw Chaminda from Sri Lanka and I saw Zoe take photos of this. So you must be thinking about this. So after these interventions, be ready to come up and share why this is important in your country context of Mongolia and Sri Lanka. So you're on notice, voluntold. Sorry. Indira, let's start with you.
Yeah, I just kind of want to build on what Pak Anies has said on regulatory sandbox. I think it's great that we in Indonesia currently ongoing process trying to develop the regulatory sandbox and maybe applying that and extending that to AI. But I think before even jumping to that again, like I think it's important for us to, with AI and being it super fast developing, the regulators also need to build their capacity before they can try to regulate, because we don't want to have what we call a regulatory arbitrage, where we introduce this regulatory sandbox, but we're just because we want to push for innovation, we're lowering the safeguards. So I think that's just kind of a point that I want to make, and especially having the private corporations being on the table, you know, all of this private driven interest, we want to make sure that the regulatory sandbox still we can test and experiment, but also provide appropriate safeguards while not to push for conformity, but to benchmark and provide a baseline to go forward.
Great. Thank you for that. Very important point. Patty?
It's really encouraging to hear what Indonesia is doing, but I wanted to share some statistics from other countries because, you know, based on data from the Global Digital Health Monitor, which Health Enabled has had the privilege of stewarding over the last few years, you know, 57% of countries do not have a protocol, policy, framework, or accepted processes for governing the clinical and patient care use of connected medical devices and in health services. So there's a huge gap in terms of what's happening, and 67% of countries have no, you know, emerging technology or AI, you know, policy and strategy that's relevant to health. So there's a very significant chasm between what's like happening and what's being put out into the world, and the regulations and the platforms for regulating it. But I was, I just wanted to say thank you to Indonesia for giving us this really great example for, what you can do. And I'm encouraged that you include civil society as part of the regulatory sandbox. I don't even think that that's necessarily the case in most other settings, that the FDA has, similar systems and processes, but I don't think civil society is like engaged as part of the process. So
Excellent. Thank you, Patty. So Jaminda, Zoe, come on up. While you're coming, before I get to you, Indira, I'm going to ask Anas a question. So Anas, tell me already from your work, what is what we say strategically reusable you see that is transferable to other country contexts as you're experimenting and embedding this regulatory sandbox approach in Indonesia?
Yeah, first of all, I think the most important is collaboration among different stakeholders, in which we are very lucky that the Ministry of Health receive or work together with us on this idea. And then they happy to invite academia and also the member of civil society, including, for example, the community of malaria. There were also several people actively as part of the technical working group of malaria to join. And also the partner from the Association of Health Tech in Indonesia, they also join this panel of regulatory sandbox. And even they work together from defining the cluster, what kind of technologies in malaria that could also be included in our regulatory sandbox. And also we publish our first report already available on GMIR, and we are in the second phase publication. And we also published the guideline for implementing regulatory sandbox. But unfortunately, it is still on a very small case on e-malaria. But there is also another book from World Bank. We also use this kind of book, regulatory sandbox for policymaker. I hope that next time we have a forum for health sector, and then we develop a guideline regulatory sandbox for health policymaker that will be useful for others. But the last comment in my my thought is that how to balance or how to combine which one in regulatory sandbox, which one in the conventional regulation, and how to work together. I think that's also another question to be discussed later.
Excellent. Appreciate that. Take your microphone, be a shark, and chase a fish to jump into the sandbox. So bring it out there, find somebody to take your seat, okay? Ah. Ah. So first, Indira, share your point.
Yeah, no, I just wanted to kind of build on what Patty said last before she went back down on civil society participation and making sure that that is embedded within the regulatory framework. Because at the moment, while civil society plays a critical role, there's actually no formal participatory mechanism that's embedded within the regulatory framework. For example, Indonesia and even Singapore having one of the most robust regulatory framework for AI. While it is already acknowledging the need of or calls for multi-stakeholder collaboration, there's actually no explicit provision as to what are the roles or status or consultation process that would involve civil society, and acknowledging the power dynamic between the government and the civil society. Sometimes these engagements with civil society are at best ad hoc or tokenistic, and it's neither meaningful or you don't really actually listen to them, and without any feedback loop that's embedded also in the regulatory framework, there is no clarity as to how civil society's voices are being heard or incorporated within the decision-making process. So when we try to develop this regulatory framework, I think it is important to formalize those participation mechanism within the regulatory framework so that engagements aren't tokenistic. Thank you.
Excellent, excellent. And I want to give a shout out to Thailand because I work in this country, but they were one of the member states that brought forward to the World Health Assembly last year to really encourage countries to make social participation an important part of the public health agenda steering, and create more obligatory emphasis and incorporation of that voice into the public health steering and agendas at the national level. So I challenge both of you, Zoe and Chaminda. Chaminda is a senior public health informatics specialist with the Ministry of Health in Sri Lanka. You both took a photo of this, one, because you thought it was interesting, two, what were you thinking in terms of why this would be useful or applicable in your country context? So let's go with the new guy, Chaminda.
Okay, thank you, Mark. So from the Ministry of Health side, Sri Lanka, we belong to that 57%. So our NMRA, Medicinal Regulatory Authority, does not govern, digital interventions. And also we don't, there was a draft policy by the IT on AI, but it was a draft. I mean, I just checked it before coming here. So basically, we don't have a clear approach how we are going to govern AI in our health system. This was interesting because we took a similar approach for interoperability in Sri Lanka. So it was a participatory, approach where all the vendors who are supplying software to the Ministry of Health, ICT department, and academia came together in one meeting, and then we did the implementation guide development then and there, in such a workshop. So I think this is very much relatable to that. And I think if we are to take approach to develop, governance around AI, this could actually work. Otherwise, if somebody says comes to the ministry, and the specific unit says, I would send this to legal department for clarity, that means he's basically killing the process. Like, it'll never come out of that legal department for years. So if you think something is bad, I don't want this to happen in Sri Lanka, I would say, okay, I'll get the opinion of the legal department. So I think rather than that approach which has been the traditional, I think we have to take more of a participatory approach, and this could work. Thank you, Indonesia, for that.
Yes, excellent. Thank you for that. So I hope this is one of the key messages from this part of this fishbowl discussion is participatory engagement from all actors, all stakeholders, particularly emphasizing the role of civil society. Zoe, what intrigued you about this slide for Mongolia context? Why could this be relevant for your neck of the woods?
Yeah, I guess I was looking at it from various different perspectives, like a citizen of a low middle income country, or a physician or a researcher. But I was looking at it, and then also if I wear my physician hat, I also want to say, like, there is nothing about us without us. So when there is a model developed or implemented at the hospital, it is also very important to have that clinician input. It's if we go to the 5 rights of the clinical decision support tool as well, that also applies to the AI models as well. Because if in an ideal world, I would also want to have that like regulatory aspect, that in the process of development of that model or solution, implementation, designing, was there a physician, was there a user involved? And then I would like to have that like human-centered design approach where they really hear from the physicians? Does it really work from your workflow perspective in terms of the format of how it shows? Does it disrupting your thinking pattern, etc.? And also, it's not also only from the physician as well, because there are so many different actors in the hospital, in the healthcare delivery process. And right now, as my part of the thesis, I'm working on a trauma registry and electronic health record system data linkage. And there are like registrars who are really affected by the electronic health record system. And there are like people who are working, spending days to find the information, etc. And we don't want that for AI solutions as well. So we also want to have like not only like legal people or the informaticians or the physicians, there are more people too, nurses, registrars, other staffs as well. So I guess that's what I was looking at. And then if I think about also, I also think that if we really want to support our physicians with the good AI model or algorithm, I also want to just say again that AI models are only as good as the data that's used to train the model, plus the developer, the data scientist, the professional who train the model, develop the model. But if I'm not wrong, most of the cases from the low middle income country perspective, these two things we have shortage. We tend to have a shortage, and then the model, that algorithm needs to be tested and validated using that population's data. And if we don't have that, how are we going to validate that? How do we know if it's even going to show good performance for our people? And then that's why I was also I really appreciated whenever there was a discussion about the digital public infrastructure, really the foundation of digital health development. How are we going to have the good data exchange? Because we need to have the data to have the AI models, and before even talking about that. So yeah, I think I will end here.
Great, thanks. So Anis brought up or asked or directed Sean Blaschke to come up from UNICEF. So he's one of the senior leads for UNICEF globally. So maybe come back to the macro lens. You've been sitting in this session, but from your perspective, what have been some of your reflections around harnessing and fortifying national systems in the age of AI, thinking about the governance, this regulatory discussion we're having, the ethics, civil society engagement, et cetera. As you wish.
Thanks, Mark. I think one of the themes that has resonated during this conversation today with me personally is the idea of that empowerment. As Patty had said, are we designing for or with our end users? And as UNICEF being a child rights organization, this is near and dear and should be part of the thinking of everything we do. And I think just stepping back, as you said, I think one of the larger questions that we're grappling with, both outside the AI space, but which directly impacts it, is around data ownership. These systems that are being developed, these whether they're child health records or electronic medical records, or whatnot, at the end of the day, whose data is this? Is this my data that I have authority, free will over, or is it the government's data, or is it the private sector's data? And I think this directly relates to a lot of the questions we have around ethical AI, regulatory frameworks, because the current thinking, or at least the current paradigm, is too frequently that this data is owned by others. We see this quite a bit with, for example, remote temperature monitoring devices for cold chain fridges. Right now, governments have to pay for this data from private sector partners. There's almost a monopoly around data ownership, and the current paradigm says that this data is owned by the manufacturers of the devices, the digital systems, the digital tools, and The deviation from that is that this is actually government data. The same often applies for systems that are managing individual data. And I think, you know, if we really want to get to the core of a lot of these ethics in AI questions, this broader issue around whose data is this, who owns it, who has control over it, really needs to be something that we collectively look at. And you know, if the current paradigm is that as individuals we don't own this data, that's something we need to start to collectively shift.
Great, thanks. You must come up into the bowl, please. You can use the microphone too. That's fine, of course, no worries. But before you make your intervention, I'm going to just ask the audience, because as we kind of pivot, we just have maybe 30 minutes or so left, if that. We've exhausted and framed a number of issues in this discussion today, and actually for the last several days. And you know, even while we were here this week, we were disrupted by DeepSeek, and we saw just in the last week how that has really shaken up a lot of the way that some of these Gen AI tools are being used in you know, giving competition in this space, et cetera. Things are moving very fast, and so I'm going to ask the audience to think about, let's pivot now. What are some actions, some best practices, some point forward thinking around you know, ways that we can really think about integrating AI into clinical workflows? What have you seen? What are some bright lights for the future? We saw many examples, but if you have any others you want to contribute, we're going to go there next. But before we do, Jay, you came back up to make a point, so please share.
I just wanted to link what was going on. Sean brought up this point about the data, who owns it, and also it also relates to the data residency as well as the jurisdiction. I think that's very important, and then that also brings to the mind like about the data governance. I think when we talk about AI, I think it's very important. We can't do that without having a clear-cut policy or a regulation related to the governance of health data. That's something that I would like to just I think that it has been coming up in the discussion, but just to summarize. And then the other way is like, I think Shaminda brought this out, where he was mentioning about, you know, unless otherwise we sit together and then do this, it's never going to see the day. That also relates to the convergence approach that which Ehin has been working on. So because this involves multiple disciplines, multiple probably ministries, including the one that is handling the law and justice, I think it will be good that if we could have a convergence approach in this policy where we can get together and then decide. Because this also reminds me on one of the projects a few years back, I think more than 12 years back, where we are working on a digitizing TB diagnostic committee. So a TB diagnostic committee typically involves in infectious disease specialist, a general physician, and then a pulmonologist and a radiologist, all sitting at different places, and then the paper or the records doing the rounds. So just reminded of that, like, you know, we were trying to digitize it, get them on board together to make a decision whether to be put a patient on an anti-TB drug, especially on the MDR or not. So I was thinking, is it possible, especially on AI, is it possible to bring together these multiple stakeholders, especially the ministers, the policymakers, and the legal specialists to work together on that mode? It's just a thought. Thank you. Over to you, Mark.
Great, thank you, Jay. I think we had somebody from the audience that wanted to speak. Please go ahead. Sure, as you wish.
Is it on? Thank you. So I'm so happy to attend in this very interesting session. So I'm World Bank consultant based in Ulaanbaatar, Mongolia. And so actually I really enjoyed listening this the needs of improving regulation of this AI-based technology in the health sector. So I'd like to share the one story from Mongolia, and I want to get feedback in other countries. So we have there is one private diagnostic center using AI for diagnostic of cancer. This center is a private company invested in this new technology and new center. And this center uses the data from Japan people because this private company collaborated with Japan. And so this, the main thing is within 2 hours, they have just the diagnostic tests within 2 hours and produces report with hypothesis of this cancer. So I was wondering, so how it should be regulated because the Ministry of Health already provided the license to operate as a diagnostic center. Otherwise, AI is not really just specifically considered or just not specific criteria for licensing of this AI-based diagnostic center. So, but it's okay. It's completely out-of-pocket visit. And so more wealthy people access to this very effective diagnostics. The main thing I was worrying is there is no future treatment in other things. So just refer these patients to other cancer center or other hospitals. And other hospitals are just starting all tests and diagnostics from the beginning because the previous one was AI-based. It's not completely accepted in the regulatory framework. So it's I received many calls from my friends. So I diagnosed with the hepatitis of cancer in my heart, but it's the location is very difficult location to make operation. So where can I go? Go overseas or just go public or private hospital? So I was thinking it's tricky. So without just following treatment in the responsibility and things, uh, it seems to me quite difficult. So do you have any experience of this kind of new private investment in AI-based diagnostics? And the following thing is like second one, because it makes a lot of profits. And the second copy of this center also established in the same capital city. And many the health workers, specialists from the public sector, is shifted to this private sector because they offer more payment. So I was thinking this is another disadvantage I am seeing, and I am worried there is something better regulation needed to prevent these disadvantages of this kind of AI-based diagnostics. So your experience from other countries would be very useful to improve this kind of regulation. Thank you so much.
Thank you for that. Anurag has volunteered to be the first responder.
So, for example, in breast cancer screening, there is a new AI enabled test in India using thermography. Now, it's been compared in some trials. It's not something that is necessarily accepted everywhere. But using thermography, people with denser breasts can avoid mammography and get a diagnosis of likely cancer. Now, exactly as you said, not every doctor, not every place is convinced of the accuracy of a thermography result. So, when the patient goes after a positive thermography, the next place will probably make them start all over again, which actually in this case is reasonable because no matter what these tests, you still don't tell you exactly where the tumor is. So, in any case, a deeper cross sectional imaging would have to be done. Other imaging would have to be done to even see further spread. So, it's not a huge problem, but it does illustrate the point that AI based tests are not universally accepted. Now, this is probably for the good because although in this specific case some trials do exist, if you look at the data very carefully, you'd probably reach the same independent conclusion that the result cannot be called diagnostic by any means, at best it is suggestive, and best seen as a triage or a screening tool, after which the usual medical care must start all over again. So I think for the large part it is good. And if you specifically took at one other example of liquid biopsies, in which sequencing is done from the blood, and from the sequencing they infer the presence of a cancer, but they can't really tell where the cancer is. Obviously, if that test comes and the person goes to a cancer hospital, well, the doctor doesn't know what to do until the full testing is done and the local area of the cancer can be identified. This gets slightly better with additional biomarkers that may point you to the ovaries, might point you to the lungs, or point you somewhere else. But by and large, as of now, for these partially validated experimental AI based systems, it does start all over again. It's only when the substrate of what the AI works on is human interpretable, then the human being can look at that and make their own decisions and go forward. But going forward in time, I do not see convergence here. Part of the reason we are going to look at AI is because it may be able to see things that we don't. It may be able to make predictions from data that we cannot comprehend. There is no possibility of full explainability of such things, but there will always remain a good, valid regulatory testing framework in which governments will need to develop data sets on which the new AI system can be applied. In India, for example, they're building MIDAS, the gold standard data set between the Indian Council of Medical Research and the Indian Institute of Science. These data sets will be kept in the private domain, not put in the public domain necessarily, or part of it will be put in the public, part of them will be held private. And whenever somebody claims to have built something that seems to work on it, as opposed to relying only on an FDA approval or a CE mark, they will be tested on the private part of the data sets, and only the results will be communicated back in terms of yes or no. So this is the way we are thinking about it in India. This is going to be a common problem everywhere. And I think there is no one single easy answer. We all have to work and think and improvise on how to go forward. I hope that was helpful.
And I don't think this is the first time we've seen this dilemma, right? Take telemedicine, for example, teleconsultations. There's a lot of lack of trust and acceptability. And here you have, it sounds like in Mongolia, individual citizens that are willing to pay in the private sector for AI enhanced diagnostics. But do they know some of these constraints in terms of the data that's being fed into that? We don't know what's in the black box, but at the end of the day, we still need human interpretation. We need to, regulate that in a way that is, future-proofing. So we have to understand that for now, this is just a decision support aid, but this has to be contextualized for when do we start putting in the regulations around the liability and use of this. And as Anurag mentioned, it's only as good as the data that's inside. And so the more Mongolian data that can be absorbed and incorporated into these models, you're still going to be relying on Japanese data profiles. So is that okay or not? And those kinds of decisions have to be made down the road. Please.
The previous question of ownership of data is going to become critical in this. And I'll give you a very simple example. Some of you might have used continuous glucose monitors by Abbott. Now there's a continuous stream of glucose data that comes out of the machine. You can see it on your phone. You can take a snapshot of it from time to time. But if you ever tried to get that data exported straight out of the device as a complete stream, they would charge you very heavily for it. The company's version is that they have discounted the price of what they sell in the market because they already consider the value of the data generated that goes to them, and they would like to create products to tell you what you should eat, what you should not eat, based on the live stream of the data that you can correlate. You can do the hard work yourself. You can even crack their API without much difficulty, which we'd have done. But the point basically remains, who owns that data? Their argument would be, your data is always visible. Every time you click on your smartphone, you can see what the number is. As many of those clicks as you can conveniently store is yours. All the other live stream that they contain, the average values are yours. All the others is there to use. Now in United States of America law, and please any American over here, correct me if I go wrong, it is written in law in many states, not all, some have corrected it, that a company can use the data for improvement of its products without necessarily obtaining the consent to the consumers. Of course, you cannot use it maliciously, but you have a right to access the data to improve the quality of your services. Now, you could argue that what Abbott is doing is part of improvement of services, and therefore they can certainly have access to all the data. On the other extreme, take the example of a genome. If a person says, my genome is mine, one could also argue back, if you only had your genome and no other genome in the world, what would be the meaning of the genome? So, in essence, for your genome to be meaningful, you have to compare it to others' genomes. Therefore, it might be incumbent upon you to make your genome and available for determination of normal, abnormal, whatever, as long as it doesn't prejudice you from obtaining care in the future. So I think this business of ownership, whether by the individual or by the company, is complicated in either direction. And that's where I want to again reiterate something I started with, or data solidarity, which was a framework that we came up with. We work on in the Digital Transformation Labs and in the Lancet Financial Times Commission. Data has no easy sense of ownership that can be defined, company or the individual. Purpose-based use of data must be allowed in some form or the other without relying too much upon individual consent. But any use of data that could be misused against the person must jump through very high bars. I'm going to end there. There's no easy solution here. It just is something to chew on.
Thanks. Patty?
So I wanted to push back a little bit on Mark. You said we don't know what's in the black box, but we have a sense of what's in the black box and the state of what's in the black box, right? So we know that, you mentioned this earlier, Anurag, that, data representation is poor, right? So data is not representative of most populations. Even within populations, it's not representative of the populations. The biggest gap that we know exists in data and in governance and in all things is female. There is a significant gap in terms of research, like clinical research, that has included women historically, even in the best of circumstances. And we know that there's a gap in representation of women in regulatory environments, in technology development, and in AI in general. Less than 20% female representation. So if I were to have like one call to action from like an equity perspective, it would be engage more women where possible at every level of development, governance, and to Indira's point earlier, it can't be like tokenism. It can't be we're just gonna like appoint a woman and not have sort of meaningful engagement. So, but we do know that the box is flawed.
Yes.
And we have a responsibility to address the flaws in the box.
Point well taken. Thank you for that, Patty. Zoe, you came back. Please.
Yeah, the discussion just made me think about the application of AI and the different areas that we can apply AI solutions. So I think earlier, which session, I can't remember, but there was a discussion about what really physicians want from AI. Do they really want the AI solutions to interfere between the patient and the physicians and really work on the diagnostics, treatment aspect? Or do they want the AI solutions to help them? Mostly the administrative tasks where they are so much burned out. So for example, like I'm not sure, like still the AI solutions technologies, it's not accepted as like a clinical guideline. Still there has to be a confirmation test, etc. So it's like a duplicate effort, right? And then because I'm from like resource constrained, resource limited perspective country, we don't have that much resource to waste. So instead of investing in that part, for example, like natural language processing is tremendous for organizing the free text, and it would be a great use of AI for the public health surveillance or like structuring the health data to support the research aspect, like generate the very nice, good, great like research data set from the clinical notes, or like the note taking for the physicians. If the AI solution handles the note taking, it would be a tremendous support help for the physician. So it's also something to consider. Where do we want to apply AI? And also from the regulatory perspective as well, there could be like different level of strictness in terms of regulating these solutions, right?
I can't resist jumping in on the physician part. So if you were to imagine a quadrant, easy and hard for AI, easy and hard for human, there will be one part of the quadrant that is easy for AI and easy for human. Now, what you choose to use there will depend entirely on your circumstances. If you got lots of humans, but even if AI is free, there is a cost to deployment. You might actually prefer to train a. So my better half is a radiologist who has AI tools. They build it for intracranial hemorrhage, and after multiple false positive problems, alerts problems, and the fact human doctors will only get satisfaction after a false alert when they have somebody to say, you are responsible for bothering my workflow. They found it much easier to give up on the AI system, ask radiographers and train them to detect hemorrhage, and they got both satisfaction out of saying, look, you will learn. AI systems are fixed. It will make the same mistake again and again and again. The radiographer, you tell them, this is a wrong AI, wrong call for hemorrhage that you made. Please learn. Next time they will do a little bit better. So when you come to the other quadrant, easy for AI, hard for human, it is going to go to AI down the line. It does not matter how we will fix the governance we've all discussed today, but it's going to go eventually. And what is hard for AI and easy for human, the human interactions involved in being a physician are going to stay with us for much, much longer. And what's hard for both is a matter of research. We don't need to talk about that today.
Great, great. We're coming to the end. So I'm going to just take advantage of the time in this way. Zoe, stay here for 1 second. So I want all the panelists to be prepared. Just give one last word of a call to action or recommendation. But also I invite participants in the audience from wherever you are. We're at the end of 5 amazing days of technical discussion. We do have time tomorrow to close out PMAC. If you have any aha moments or reflections that you can summarize in 1 minute, I welcome you to please come to the mic as well. So Farah, I want you to make your intervention and then share and convert that into either a recommendation or call to action. And I will just say, of course, we just have hit the tip of the iceberg. We've had so many rich discussions the last several days, but in this session, particularly around the importance of good governance from an ethical standpoint, thinking about the regulatory aspects, looking at patient clinician workflows, efficiencies, thinking about stakeholder engagement, et cetera. These are just some of the hot buttons of the importance of getting it right. And we have so much collective experience in digital transformation over decades. So let's make sure in the area of AI that we do it very well, and as I like to say, we do it right and not rushed. So that's my last word. But I'm going to ask Farah, if you could share your point, make your call to action recommendation, and then I'll ask the other panelists and anybody in the audience.
So look, my call to recommendation is essentially to take a multidisciplinary approach. And I say that because Zoe's comment kind of reminded me about what's happening on the ground in Australia at the moment. So our general practitioners, primary care physicians are overburdened with documentation, more than, pretty much near universal computerization, but they don't have enough time to keep records. So essentially, we've had generative AI being introduced, AI scribes that are creating summaries of consultations that the practitioners then need to review and accept it into their notes. So essentially, it's helping them with documentation. It's available in most primary care software packages at the moment. It sits outside of regulation because record keeping software is not regulated. And so the response to that has been from the College of GPs and the Health Practitioners Regulation Agency to essentially put out quickly guidance around what these things do and what the responsibilities of practitioners are. So it's been a multidisciplinary approach where these organizations have worked with experts on patient safety and AI to say, look, this is the guidance we're putting out. Can you guys look at it, make sure that it's making sense? And so essentially working and across borders in terms of cross-sector approaches and responding to problems as they emerge.
Great.
So
So
thank you.
a few points there, multi-sectoral partner, all of that. But I think I've heard many times the last few days, let AI do the boring stuff. Isn't that like a good start? And you know, we're all using AI, ChatGPT and other Gen AI tools in our regular work. So of course, I think we can eke out efficiency there. And I like the idea of these AI guides, this concept that you were discussing as well. So thanks for that. Zoe, what is your final reflection or comment?
Yeah, I was thinking about the aha moment. I guess I really liked the message that said, "Let ethics guide the AI." So, for example, if we think about the how we let ethics guide the AI, I also thought about our principle from our society colleagues. So there are like 6 important principles. Of course, there could be like different perspectives, but to guide that, we really need to have that stakeholder engagement, listen to everyone, engage everyone on the ground. And I also really think it's important to not forget the most vulnerable population in the country, because I'm a little bit concerned whenever there is a like digital solution or AI, like high tech things, we cannot let the technology guide all the services. There must be always an alternative option that is not high tech, so that it's not a block to that population that's blocking the service to them. So I guess like let's let ethics guide AI and try to look at all the principles that we have to follow if we want to implement the AI responsibly or ethically.
Great. Thank you for that. Matt, I think you were going to make a point. Can you come to the mic? Patty's point was gender balance in the data infusion and other aspects around equity. She says she's okay with that as her main last point. Indira, why don't you share your point, and then we'll hear from Matt.
Yeah, my point is that I would call for the co-production of AI policies, that government or the private sector should not make AI policies for the people, but it should be with the people. And that while that participatory approaches would take time, but that co-production itself also accelerates the implementation and ensures that that is actually representative and also appropriate for the local context.
Excellent. Thank you for that. Matt Hulse from World Bank, please go ahead.
Thanks, Mark, and all the panelists for the chance. I really enjoyed the fishbowl. I thought about coming up there, but the comment I was going to make was going to cannonball some of the water out. So I'll use that opportunity to do it now and add a bit of challenge. And while I'm a huge advocate, and I hope through my own institution's work and my own personal work to like advance a lot of the equity, but I wanted to put on the hat of maybe the chief information officer role in the ministry. You know, I didn't meet any of those here yet at the conference. Who's got a team on the basement level 2 of the ministry, plenty of women maybe working on his team. And his day job is to do like ISO 27001 compliance on cybersecurity, or the IEC 634, you know, the medical device management. And, you know, to him, that's the hardened health system. And in fact, Iran's example of that hospital that didn't accept your test result because it's not proven, like, that's hardened. That's good. That system's not adapting to use what you're doing. So it is hardened, and it's resistant to change. And And while I think a lot of the conversation of the conference has been some things have to change, can we embrace or harness that change? Um, I think there's some missing voices on maybe the hardening outside of, it's not hardening AI, right? It's hardening the health systems. And there's still a lot to be done, even without AI, to protect those systems so that they might not get abused by the malicious types of services that could take our claims data. Or I'm really worried about that set of technology that says, well, I got to cancel all the beneficiary numbers because they were frauded and hacked and that was malicious. So there's not that many sessions. There's a lot of sessions talking about promoting the equity and promoting the inclusion and promoting the best practices and being brave and needing that reform. And it's going to happen in parallel with those that are still trying to keep those health systems running well, running reliably, being the last point of care. And a lot of folks said, well, we all have to do it together. And so it's just a call to action to also involve those engineers, those people in the basement, the men and the women, the chief information officers, the security standards, as well as the governance and policy standards, because I think together that's how the system stays hardened and healthy.
Thanks, Matt. Appreciate that. That's some sage advice. Again, some more of the boring stuff, but it's also essential, some of the digital public infrastructure. Honest, grab a mic. You're also one of the panelists. You have a last word.
Just one thing related to our experience on malaria regulatory sandbox. When we found out compared to the second or the real regulatory sandbox, we found that a startup are not interested to malaria because they don't see any profit on malaria. So I think in the next step, we also need not also we need inclusive as well, that a neglected disease should also be part of this innovation. I'm worried that people talking about mostly on telehealth and new technologies that from the perspective of startup companies are profitable, but for certain program are not profitable. So we need to call for development partner also to invest on especially the neglected disease and also rare disease using this kind of new technologies.
Fantastic, fantastic. Thank you for that. Anurag, you have one more last comment in you, and then I think I'm going to turn it back to you.
I'm going to take Matt's point to say something that neither best practices nor ethics can be derived either from logic or from the data of real society in the world that we live in. And this must come from the top, what Matt refers to as the hardening, and that's governance, and it's necessary. So I think just amplifying his point, and I think that's important.
Great, excellent. Rasham is dropped? Okay, wonderful. I want to congratulate our panelists for job well done. I think we got a lot of diverse input, and I appreciate many of you from the audience who stepped in. So let's give a round of applause for our speakers and volunteers. I appreciate that. And I will turn it over now to Jay to close us out. Thank you all for coming. I hope that this maybe helped to synthesize and bring together some of the points that have been raised. I think we're just trying to look at this in different ways. I really think we had a really cool, diverse group to share their insights, and appreciate you indulging us in this fishbowl style. So Jay, over to you. Thank you so much.
Thanks, Mark. Please stay on. It's an honor to have this privilege of hosting this panel and having you all, both speakers as well as the participants. I know it has been a very long day for many of you with many sessions, and then sometimes on similar topics. But it was great having this kind of interactive style. And I would like to thank Mark for being the moderator and having the fishes engaged here, and then having a very interactive session. And then this is the time that as we wrap up, I have the pleasure to invite all the speakers onto the stage, and we will have something for you. And then we will have a group photo with everyone. Please stay on till then. Thank you.